Thanks, Trung. Good morning. I'm Jason Barron. I'm one of the medical directors in the core lab at MGH, and I'll be talking this morning about machine learning-based clinical decision support for laboratory test interpretation. But before I do, I want to draw a brief analogy to an application of artificial intelligence outside of healthcare. I'm sure that most of you have had the experience of getting a call from your credit card company telling you that there has been suspicious activity on your account. Perhaps the caller tells you that your credit card was used last night to make a $129 purchase at Best Buy. As you tell the caller it wasn't you who made this transaction, you wonder how they were able to suspect fraud. What was happening behind the scenes? What do you picture? Do you picture someone from the credit card company sitting in a cubicle sifting through thousands of credit card transactions trying to spot the one fraudulent one? Of course not. That would be ridiculous. You know that computers must somehow be involved, probably some type of machine learning. But despite how ridiculous it seems that someone from the credit card company would sift through thousands of credit card transactions manually, that's exactly what we expect of physicians when interpreting laboratory test results. In fact, most laboratory test results are actually interpreted by physicians looking at tables of numbers. Over the next 8.5 minutes, I want to point you towards a vision for a better way of laboratory diagnosis, one that can improve diagnostic quality and hopefully save scarce clinician time. So what is this vision for a better way? Well, and why do we need it? So as the credit card analogy alluded, patients may have hundreds or thousands of individual laboratory test results, often spanning many years. At present, clinicians must manually assimilate and interpret all of this data for accurate patient diagnosis and management. Now, as you might imagine, this current practice is suboptimal for several reasons. Foremost, tests have complex interrelationships, so it isn't sufficient to consider individual tests in isolation. Moreover, the human brain isn't well suited to high dimensionality data, such as laboratory test results, and so it's likely that complex patterns often get overlooked. As a result, we expect that in many cases, the transformation of lab data into actionable information is limited. In other words, we're not extracting all of the useful information that we could be from the diagnostic testing that we perform. And finally, this process of manual test result interpretation consumes scarce clinician time that could likely be put to better uses. So what is the vision for a better way? Well, it's shown on the right-hand side of this slide. As shown, at present, most of our laboratory test results start out in some raw form, such as an electrical signal generated by a sensor. Generally, what we do with this is we convert these into atomic data elements, which we then report to clinicians. So for example, as shown in the schematic, we might tell a physician that the patient's ferritin is 26 or the patient's MCV is 82. And then we leave the rest to the physician to interpret and make the diagnoses. However, in our future vision, which we call computational pathology, we would apply artificial intelligence to this atomic data to take this several steps further. So for example, perhaps we could take this set of test results and using our algorithms, we could append a comment to them when we report them out saying something like the CBC and iron studies are suggestive of iron deficiency. We would like to even take this a step further and integrate this data with information in the electronic health record to be able to produce integrative summaries. So perhaps we could note that this patient not only has iron deficiency, but there's symptoms that are suspicious for colon cancer, and that might be causing the iron deficiency. And finally, what we really want to be able to do is to come up with patient-specific information and predictive and prescriptive information. So maybe continuing along with the analogy, maybe we can actually give a patient-specific risk of having colon cancer and recommend to the physician that he or she consider colonoscopy. So our group has worked on some of the artificial intelligence underpinnings that could serve as a foundation for our future computational pathology. And one example that I'll talk to you about this morning relates to the test ferritin. Now, continuing along with our theme of iron deficiency, ferritin is a marker of iron stores, and it's used in the diagnosis of iron deficiency. Patients with iron deficiency tend to have low ferritin results, but ferritin must be interpreted in the context of other analytes. To explore ferritin, we started out with a set of outpatient test results that we extracted from our laboratory. in fact, as shown in the heat map, we had about 5,000 patients, where each column in the heat map on the bottom left is a patient, and each row is a different test. The top row represents ferritin, our particular test of interest, and the other rows represent other tests. The color of each cell represents the scaled value of that test on that patient, and the white spaces represent tests that weren't performed. So we can already start to see some interesting patterns. We see that when ferritin is blue, in other words, ferritin is low, some other tests also tend to be correlated with it. They tend to be blue, and other tests tend to be inversely correlated. They tend to be red. We next ask, well, can we predict what the ferritin is without actually knowing it? In other words, we said, can we cover up some of the results from this top row and then recover them using the other information we have available? To do this, we used a two-stage imputation procedure, where we first predicted the missing non-ferritin test, in other words, the tests that weren't performed or the white spaces in the heat map. We then used this completed data set to predict the ferritin test results. As shown in the ROC curve, our best performing models were able to determine whether ferritin was low, suggestive of iron deficiency, or normal with a high degree of accuracy. We were able to achieve an AUC of about 0.97. We next asked, well, what does this really mean? What is the value of reporting ferritin? And so we did some chart review of cases where our algorithm predicted that the ferritin was low, suggestive of iron deficiency, but the actual ferritin that we reported out was normal. And we found that our algorithm was actually better representative of the patient's iron status than the measured ferritin that we're reporting. And in fact, we found a few cases where we think that the physician may have missed a diagnosis of iron deficiency, relying on a normal ferritin result, but our algorithm got the diagnosis right. So what could we do with ferritin? Well, we see a few applications. Perhaps the most direct one would be in detecting anomalies. So perhaps every time that a patient has a measured ferritin performed in our laboratory, we could also calculate a predicted ferritin value and report the measured ferritin with a comment if it's discrepant from predictions. So maybe we could say something like, this ferritin result is inconsistent with other testing, and instruct the physician not to rule out a diagnosis of iron deficiency on the basis of the ferritin alone. We could also flip this around and try to find cases where a ferritin wasn't ordered, but we nonetheless predict that it might be abnormal or the patient might be iron deficient based on the other labs, and we could actually suggest ordering a ferritin. And finally, we could potentially eliminate redundant testing. So although ferritin is fairly inexpensive, we could apply similar approaches to high-cost tests to predict the results of them using a set of lower-cost tests. So how do we get from examples like ferritin to our big vision of computational pathology? We see several next steps. First, we want to extend the ferritin approach to a suite of other laboratory tests and diagnoses. We have some other data, which I didn't have time to talk about this morning, which suggests that similar approaches are extensible. And working with colleagues from MIT, we've worked quite a bit on time series-based models. We have a large set of data in our laboratory. We have over 1,000 tests on our test menu. And so we have no shortage of candidates to apply this approach to. Some of the ones that we're interested in looking at next might include immunologic testing for various rheumatologic diseases and testing for congestive heart failure. But we ultimately hope to scale this up. We next need to consider or develop external platforms to implement these algorithms. And then finally, we want to do a prospective validation of them in clinical practice. So we want to implement our algorithms and then do a prospective trial to determine their impact on various clinical and financial metrics. I'll end by discussing the fact that I think, at least I hope, that we're well suited at MGH to solve this problem. We have a large set of accessible data in our laboratory, and our group not only has experience with these AI-based algorithms, but we also have quite a bit of prior experience implementing rule-based clinical decision support. And so we think that the key to solving this challenge is going to be to integrate the rule-based, our experience with general clinical decision support with our AI knowledge. I'll end by noting that everything I talked about today with the ferritin and much of the other talk has been a team-based approach, including Anandi Gay, our core lab director, and Peter Solovich, a computer scientist from MIT. I'd be interested in chatting with any of you who might want to discuss further out in the foyer after this talk. Thank you again for your attention.